Thank you very much. Good afternoon, everybody. I just presented the last session our experience in gastric cancer, but I'm mostly a bariatric surgeon rather than anything else. So I'm going to present a broad analysis of the first 700 sleeve gastrectomies that we did in my hospital, which is a Noor Airport hospital in Abu Dhabi. It's a private hospital. I just talked about it a few lines in the last session. Well, the Bariatric and Metabolic Center of Noor Airport Road Hospital started late 2008, and since then we're performing various bariatric procedures, including redos. The criteria of selection and multidisciplinary pre-op preparation and management of the patients is governed by the ASMBS guidelines, of which I'm a member. We have a dedicated team of professionals, all what it takes, besides the surgeon, we have the pulmonologists, the endocrinologists, the intensivists, psychologists, cardiologists, nutritionists, and the supporting services. We have a dedicated team for the bariatric service. As a matter of fact, they don't only do bariatric service, but a part of their daily work is dedicated to bariatric service. The sample size for this study is 715 patients. By now, we have done around 1,000 cases, but the study is limited to this number. All operations were done by the same surgeon. I'm actually the only surgeon there for most of the time. The thing that I need to mention, which is, in my opinion, related to part of the outcome, is the evaluation of the technique. And before that, I never used any sort of support to the staple line in the first 200 cases. And after that, I'm almost exclusively using buttressing materials for all cases. And the comparison of the data, as you actually see, will not show any difference other than one thing. Probably the leak was relatively less with the, although there's very few cases, but it's relatively less in the case of the buttressing. But the main thing that changed the technique are those. In the first 50 cases or 60, there was no clear guidelines about how much you go close to the esophagus. And I used to go rather closer than I'm doing now, but after the first 50 cases, I started doing half a centimeter or so from the esophageal junction, which is a standard procedure now. And the other thing that changed after the first 200 cases is the distance from the pylorus. I used to do 6 centimeters in the first 200 cases, but for the rest of the cases, I'm doing 3 to 4, generally 4 centimeters. And I believe also it had something related to the outcome, just that I'm going to talk about. We randomized the patient into 6 samples, 6 cohorts, depending on the year of their management. The patient operated upon 2009 were group 1, and so on up to the patient who were operated upon in 2014, which is group 6. And we collected the data, mostly the BMI, diabetes, lipid profile, uric acid, on admission, and we made some sort of an analysis between the outcome. What we managed to collect was those. You see, it depends on the cohort you are in. For cohort 1, we managed to get everything. It's all there, if you can see. For cohort 1, everything was there. The BMI, excess weight at 2 years of admission, excess weight at 5 years because there was enough time, 3 to 6 months, and the last post-operative follow-up was included. But then it varied amongst the 6 cohorts because of the time lapse between the first visit and the last visit. And the results will show that. What did we collect? What are the data for the variables that we collected on admission? We have noticed that the population is rather young. You see the average age is around 34, actually it's 33.8 years, which is quite young. The average BMI was on the high sides, it's almost 48, 47.96. 40% were diabetic, 31% were hyperemic, and more than 50% had hyperlipidemia. The vast majority of our patients are predominantly Emirati patients because the practice is basically insurance-based, and the insurance is exclusive for the nationals. And as you can see, female to female, male to female ratio is not that significant, actually. And the average BMI is there for the cohorts. There's one interesting finding. If you see the average presenting BMI for the people who had the surgery in 2009 was 49 versus like 43 on 2014. And I believe part of the significant part of this is because of increased awareness of the problem and trust with the local experience in getting good results. Because 2009 people probably were afraid of doing it here and rather doing it outside, or they didn't believe that surgery was an important thing. As a matter of fact, a lot of people still now believe that, in this part of the world, believe that excess weight is a sign of good health. But it's, of course, reversing now. And I believe this observation is also a part of it. It's a big difference. And this, I'm sorry, something happened to the first slide here, but it's actually a bar diagram of this line diagram. This is the excess weight loss. This is important, actually. And again, I have no proof of what I'm telling you apart from the numbers, but probably something has to be done to prove it, at least to my own knowledge. I'd love to hear from the audience. Those are the people who was done 2009, and if you remember, 2009 had 6 centimeters from the pylorus, not 4, and their excess weight loss was that's at 2 years, and that's at 5 years, which is around 46%. The same thing applies to patients with 2010, the same technique, 6 centimeters from pylorus, and you can see that the excess weight has dropped from 42 to 35, which is roughly 45%, close to 2009. It changes dramatically in 2011, where I started doing 4 centimeters from the pylorus. And if you look at the numbers here, the excess weight loss at 2 years for patients who had this for the first time is 71%. A big jump from the 40-something we had before the 6 centimeters. And again here, for patients who were operated upon 2012, from 48 to 31, it's like 69 point something. Well, most literature says that when you go closer to the pylorus, it will definitely affect the speed of your weight loss. Your patients will lose weight quicker than those who will have it done at 6 centimeters. But so far, there's no solid data saying that the final outcome would be better. As a matter of fact, most studies conclude that at 5 or 6 years, they actually attain the same weight loss. But, I only have one cohort that reached 5 years. I can't comment. Probably in 5 years' time, we can check the data again, and we can come out a conclusion. In profile, you can see that the average weight loss is there. So the BMI was 47.48 on admission, and on 2 years, the average overall, all cohorts, was 35.2. It was something around 43% at 2 years and 66.3 at 5 years, which is definitely on the high side of most international studies. For diabetes, it's more or less consistent. Again, this is profile 1, and that's profile 5. Profile 6 was too early to comment on. And you can see 36% of the patients on admission were diabetic here, and after 1 year, 13% were diabetic. And this number actually, something happened here. And this year, insurance was halted, and we did only 10% of the number we do generally. And the results were independable. You can't depend on them. But for the rest of the graph, where we're doing the regular numbers, we did actually like less than 10%. We did actually like 12 cases here. We do an average of 250 a year. So the rest of the graph is the same. There's a dramatic resolution of diabetes from initial 39% to 11% of the patients at 1 year. Same thing applied for hyperlipidemia, from 55% to 31% at 1 year. And the same thing with hyperuricemia. Probably the hyperlipidemia was the slowest to recover in our series after, or to resolute after the procedure. The results with diabetes and hyperuricemia are much more encouraging. The complications we had were actually 6 leaks out of more than 150 by the time we did the analysis, 0.7%. 2 of them were redos, which, you know, the likelihood is much higher. And 2 of those cases were in the first 30 patients, where I believe, well, the expertise was less, and the technique going closer to the esophagus might have contributed to the number. We had 5 cases. By bleeding, I mean the patients we had to take to the theater again and you know, remove the clots and clean the area. And there were only 5. Interestingly, we could find only 1 leaking vessel at the staple line, and we couldn't find anything in the rest of them, absolutely nothing, which I think very common. We had 1 collection only, and this is not the scope of his presentation, but he presented with something like very much like a leak, a late leak, like 3 months post-op, low-grade fever, and the CT actually suspected a leak. But when we went in, it was a collection, pus, and the patient did very well after clearance. So it's a very young population with a high-end BMI. It's a safe procedure just like anywhere else, significant excess weight loss. I believe our numbers are a bit on the high side of the international literature, and there's significant resolution of comorbidities, especially for diabetes. And this is increasing in increased acceptance by the patient, as the graph showed, the first one I showed. Thank you very much.
Question, please. The percentage of failure of a sleeve gastrectomy in your experience,
Yeah.
in case
Failure as defined by weight regain, or yeah. You know, thank you very much. But I think RCs are too young to judge about weight regain, because only 1 cohort has passed 5 years. But still, out of the 1,000 we did, the problem is sometimes your patients might go somewhere else and you can't know about them. From my own series, I got 1 patient who gained weight enough to be re-investigated, and we're checking him. We're working up. But it's too early.
what you proposed for the failure sleeve gastrectomy?
It depends.
Bypass,
I believe.
mini bypass,
Yes, I believe. Yeah, I mean, the literature has so many opinions about that. I'm with this school that says if the sleeve is wide enough for a re-sleeve, then I'd re-sleeve it. And I have done that for quite a few patients who were not my own. But if the sleeve is not really wide enough, then the first thing is you have to investigate your patient's eating habits and his psychological reaction to the procedure. And once you make sure that he is really doing what he can, then bypass or a mini bypass is the choice.